Hello, and welcome to another episode of Dentistry Beyond the Numbers. Woo, we are growing, and I'm loving it. I'm loving the people you have seen me interview and talk about. Love the procedures we're getting people to think about. But, we talked a lot about how to make money, how to be a great dentist, quality dentist, comprehensive treatment planning, and we're going to continue with that. Speaking to people like Howard Ferran, Gordon Christensen, expenses like Chuck Cohn. We spoke to Kim Cooch about caries detection. It's been a great ride and it only continues. But to me, something is extremely valuable that we're going to touch on and start touching on today. And it elevates itself from the palm of the dental hamsa. My roadmap in this whole podcast situation, this is what I'm doing, right? So the first 5 things, the fingers, the leader, gives us the procedures if we can remember. Right? Root canal, clear aligners, crown and bridge cosmetics, implants, and surgical extraction bone grafting. Getting the ridge ready. I just had a case from a dentist that sent me a potential treatment plan for a bridge. Patient came in pain. The decay went through the FERC. 18, 19, 20, 19 being an abutment, being the pontic. A doctor who is a super generalist sits down, marry the patient, gets them numb, gets all the paperwork out of the way, and the treatment plan is simple. First molar occlusion on top, take out 18, surgically extracted, grafted for ridge preservation, and put an implant in, a 19. No need for another unit. I just think when we look at the breadth of what this brings, it gives us that treatment planning ability, the ability to do a lot more. Today, we want to find out how we're collecting our money. Every time I go into a new practice or my own practices that I built, collections could be at 92, 93%. And I've got to tell you that some of us are okay. That's great. Why? Why are we okay with giving away $7, $10, $15, $20, $30,000 a month? Because it's okay if we collect 92, 90, 85%. I think today's world with the things that are going on, we need to learn how to collect 99 to 100%. In my practice, we want 105, 106%. We want cases paid in. So without further ado, I thought we'd bring in the best. I met this young lady about a year and a half ago, or maybe 2 years ago in Houston, and I was blown away by the jubilation she had when she was talking about collecting our money, the doctor's money. I like to keep this, but this is essential because I come in every day and I ask my team, where the collections at? What are we doing? So I want to say that our guest today is none other than one of the fastest growing insurance, maybe CRM, whichever way you put it. We're really generating this outlook of putting it all together, everything that's collections. But Bri is an expert in collecting our money from insurances and beyond, and we're going to let her talk about it. I just want to say that Bri is a dental insurance billing powerhouse with years of hands-on. There she is. Experienced practices clean up their AR, get paid faster, and stop leaving money on the table. I am tired of that. From virtual sessions to in-practice training, Bri has seen it all. We're going to talk about why so many practices don't collect everything, like I've just mentioned, that they're owed. If being paid within the first 30 days is realistic, is it realistic anymore? Are they floating our money? And what you can do right now to take care of your control of your collections. I hate reading it. I just want to say you are always up. You're always giving insight. It's an honor to have you, Bri, and I can't wait to talk about everything collections. Welcome to Dentistry Beyond the Numbers. How are you, Bri?
Good. Thank you for having me.
Great. Well, and listen, we were talking about doctors questioning me a tremendous amount, saying, what do you run your collections at? What do you run your collections at? I said, something? We met. I need to get her on because she was just full of ideas. So before we go further, I really want to hear about your background and tell the listeners and people that really are going to really cuddle up to you in the next couple of months, I hope, to find out how we can get collected. But tell me, what's your background and how did you get into this?
Absolutely. Thank you. So I started as a dental assistant in 2009. Absolutely loved it and accidentally fell into the admin side when I moved to Texas and Linda Miles said, "Hey, I've got a friend there. Let me introduce you." So Dr. Coker wasn't hiring, but he introduced me to Dr. Morgan, who was. And he said, "You know what? I don't have a spot for an assistant. Do you want to work at the front?" And I was like, "Yeah, until an assistant position opens, that would be great." And as it turns out, I really love money. So that's how it started.
Wow. Dr. Morgan, he turned you on to money. Go get him, doctor. That's awesome. Well, I don't know if it's good for everybody that but it's good. And by the way, I mean, that's what I found when I met you. I mean, you were really excited, but I want to point out something. I always preach communication. And it's your communicative skills that probably vaulted you to such, you know, being involved with money. And he who was involved with money generally is involved with some of the decision making and just become more valuable in the practice. I think it's phenomenal when people use skills like that to elevate. And communication is something you have a gift of. And I think it's great. And it helps doctors treat and plan as well if they can really speak to the patients. Why do you think collections and AR are so downplayed? They're just dental offices don't even address it to the extent we should. Who do you think that is?
Well, I think, like you were saying in the beginning, there is this notion of like, well, we're doing okay. I collected 100,000 this month, but if 100,000 is 92%, or whatever the dollar amount is, it doesn't really matter. I mean, if you can increase your collection ratio 5% for $1 million practice, that's $50,000 over a year. And why not? Why do that for free when we can create a system that honors both the patient and us and our practice and gives us the freedom to be able to do all of the things that cost so much and that could elevate our practices to the next level truly, but they're expensive.
I want to tell you the way I look at it. I look at it as because I've run a number of practices. I've been fortunate enough to run a $5 million office that I sold, and it was phenomenal to have such a successful practice. And it's not just me doing it; the collections, the billing, the associates, everyone's involved. But the true point is the way I look at it is if you're at 80% of your collections, I want to start this off by getting people to understand how important this is. If I have phenomenal doctors and we want to pay them on collection, not production, because we know we're at 80%, when they find out we're at 80%, they're leaving us because they don't want to get paid at 80%, or they're telling you to pay them on production. Now, the way I look at 80%, let's say to your point, you're a $100,000 producer. And listen, you collected 80,000. There's 20,000 that was not collected. But it cost us 10,000 to make that 20,000 because we run on a 50% overhead. So our 80,000 collection was really 70,000. And that's what we're basing our. So to me, I'm asking you, do you find that doctors and the mindset of people around the industry are that focused, understanding that what's not collected, you're still paying bills for?
I don't think that there's a big focus on it. I don't know that it's intentional or just sometimes they just don't know. Like, for example, I train teams in office a lot. Like every other week, I'm in a different office. And we run the AR report when I'm there. Sometimes we run it on the phone earlier. Sometimes that's the first time. And what I find a lot of times is, number one, they don't know how to run the report, which first of all tells me that they're not looking at it. The second thing I find is that more than half the time they're really surprised at the amount of money that's stuck on it. And then it's a little panicky. Like, what do we do about this? What do you mean I have $500,000 on my AR report? Can we get that money? And it's like, yeah, some of it, but how old is it? Is it 10 years old now? So we have to figure out a system to make this turnaround a lot faster and get it paid very quickly so that it's not getting stuck. And then when it gets stuck, you're not going to recoup 100%.
Here's the realistic turnaround. I mean, if I'm doing 3 crowns, got a great approval for, let's say, $4,500, no maximum, sending it in. I got a few things on that. I mean, obviously the question from a doctor who has practices, I mean, what slows that down? I mean, you understand these are people that work in this department that have done it before. What could possibly slow down a payment? Isn't it rinse, repeat, and just do it again? I mean,
Well, there's two sides to the payment. There's the patient payment, and then there's the insurance payment. So what slows down the patient payment is that sometimes the team struggles to understand how to estimate copays accurately, or co-insurances. It's really co-insurance most of the time, but not everyone knows that word. And then foreseeing the denials, because it's not very often you're getting a $4,500 payment from any insurance company because they max out at $1,500. Or you're replacing a bridge and the old one was only, 3 years old or something. So you have to have your team really trained on how not only to use the software to do the math for you, which, by the way, your practice management software is a fancy calculator and you shouldn't have to use a calculator. If you set it up the right way, it will do the math for you perfectly every time. But now you have to manually catch those denials. So you have to have a system that's really easy. Your team does not have time to go through 25 pages of an insurance breakdown to look for code level things. They need it concise and distilled down to the stuff you actually do, organized by the group number so it all shares. And then they can collect enough upfront. So that's one place it gets stuck. The other place is in the insurance part itself, because not every insurance company requires the same thing. There are some insurance companies that, like for a gingival scale, you just send the claim and it's fine. And then there's other ones they're going to deny for x-rays and periotarding. So teams don't always have a clear understanding of what they need when they send claims. And even the language of the narrative, or if they're using clinical notes, if everything that the insurance company needs isn't included, now that claim isn't paying the first time. Now it's delayed and you're not at 30 days, you're at 60 or 45 or whatever it is.
but we generally know what insurances ask what, correct? I mean, it should be, let's say Cigna asks for a pre-post. I do have a question. I mean, pre-ops. Some people come in and, having the fortunate ability to look at a lot of practices in an acquisition state. I look at what their lag is from diagnosing. I always believed, on a side note, single crowns, an x-ray, you can get started right away. Do you find that's a hindrance with a little narrative? I mean, because we'll be sitting around waiting for approvals to come in. I find that with an x-ray and go, you could start pretty soon.
Oh, 100%. I think that pre-authorizations they're not completely unnecessary in every single situation, but 95% of them, they're unnecessary. But they're a crutch. So if your team is struggling in
this contract, right? You have the contract. We have the paper. Some patients want it. Some doctors are savvy enough to talk themselves into the treatment right away because, to your point, there's that co-insurance. Where are we losing the most money? I mean, where a practice is losing money in the collection process? I have my frame of reference of where I think it is, and I surprisingly do not think it's in the insurance.
I don't either, actually. I think it's in the patient collections. And I think that it's partly because the insurance coordinators feel a little bad and sometimes they're a little confused. So if you put those together with a patient that is kind of putting a little pressure on you, you feel guilty to collect enough upfront if you're not sure yourself. So what happens is they feel like, oh, this is the compassionate thing to do. I'll collect a little less. Or the patient asked, can you just bill me later? Well, then they don't pay it all. If the patient says, can you bill me later? That is the same as you going to your doctor and saying, hey, doc, can you pay for this?
Bri, it's a great point because my fear has always been being in New York City with big ticket treatment plans, major mouth reconstructions, 30, 40, 50,000 and more, is that people are going to come up, they come in, we either do it in the chair or a treatment room, and we do not let people go to the desk. I do not talk to people. I always have a philosophy about this, and that is, if we're going to get into this, I really didn't know that you had such in-depth in the practice. It's phenomenal. But you're right. I try to avoid our patients with our treatment coordinators looking at the front door. I feel that we're going to present to them treatment. If they look at the front door, they're looking at an exit, and the exit is their salvation for not spending the money. But I find that not enough people feel that if let's say I'm making $50,000 a year and Mrs. Smith comes over and she's immensely wealthy and she needs a $60,000 rehab and she's ready, but the young lady who's the treatment coordinator go, wow, that's a lot of money. I mean, that is a hindrance in our field because it's a very top heavy, right? So what do you do about that? I mean, how do we get people to look at the actual work a doctor's going to do or the beauty the patient's going to have as an experience? Go ahead.
Well, that's a great point that you bring up. And I think some part of it is just you just have to separate yourself and you have to separate your own financial situation from the patient's. And also, okay, I ask this question a lot with the pre-auth conversation because I'll ask the dentist on the phone when we have a conversation before training, do you send pre-auths? And they always say, almost always, only on the big stuff. And then I ask them, well, what's the big stuff? And usually the answer is $5,000 to $10,000. Then I ask that same question to the team, and the team 99% of the time has had the same answer. What is the big stuff? And they say 1 crown. So sometimes there is a disconnect between even what the doctor thinks the team thinks and what they actually think. But we just have to get to the mindset of like, it isn't my responsibility to determine if they can afford it. It's my responsibility to do the best thing for the patient, to, if I need to be creative, to have financing options that can make it affordable. So if they need to spread some payments out, we can absolutely do that. It doesn't mean the doctor's paying for it. It doesn't mean that we're taking on the financial responsibility, but maybe we're using a third party that's really good.
I'm getting excited because there's so much to this. There really is. There's such art form of how to treatment plan, how to sell. I pride myself on being an incredible communicator and salesman, but dentistry can be a rude awakening. But I do find that in my career, I had this one treatment coordinator, and everyone who knows me would know the name right away. And she used to be amazingly excited when she would sell a big case. It would really get the whole practice up. I just feel a treatment coordinator in either / insurance person, but a financial person's upbeat needs to do one thing more than any, and that is have confidence in the practice itself. And that is an immense important to me a point. I always tell our doctors, the most important people to impress are our team. Our teams, because, right? Because if you go in and you say, well, Dr. Jones wants to do anyway, I would go somewhere else. Like we want people to go, hi, Mary, Dr. Jones says you need 3 crowns. He's excellent. I'm telling you, we get great reviews from him. We need treatment coordinators to not just spew numbers, but spew confidence.
Yeah.
And that's true, right? Isn't that just, being somebody like you who looks empathetic when you go in and sell a case, we're feeling for that patient. We want that patient to have great results, but we want to collect every dime, which segues me into this. How involved should a doctor be? How involved? I have a practice we're looking at in the group, and the doctor does all the billing. And I'm saying to myself, how much time would he have on his plate if we take away the billing? That's eccentric. But how much should somebody a clinician be involved in the collection, if at all?
Well, I think that especially the owners and people that are paid on collections should be involved to some level because, okay, my favorite entrepreneur, Cody Sanchez, says, money is like a bad mistress. Pay attention to her or she will leave you. What you give attention to, automatically, you're going to
comment on that, by the way.
But you're going to be paying attention to making it better more. So I think that there should be a system in place where maybe the doctor's not doing the collections. Hopefully they're not doing the collections, but they still have some sort of reporting involved. Like every month they're getting the aging report and the stats, and like they can see the last month. Are we getting better? Are we getting worse? Because if the train starts to wobble, we want to catch it on the wobble. Like, well, our over 90 is 13%. Last month it was 5%. We don't want that over 90 to be 46% before we realize it, but so often it is.
I'm going to get into that into 1 second because I'm going to ask you early signs of that train coming off. I do feel what you said is very important. And I really, when I was full-time in one big practice, I would know exactly if we're doing a large case, how much was put down the first visit and what we're expected to get. Because even if you're being paid as an associate on collections, the reason you're being paid on collection is because we want you to take control of your own book. We don't want you to do the fourth, fifth crown if we didn't get paid on the lady for the second and third crowns. And just like that, we should know, I agree with you 100%. We should know what our book is doing and how we're doing and if that big case is going to collect today. And before you put in those 8 laminates, we have to get out of the mindset that we are the last to get paid. We need to get paid before you put in the laminates. And the patient, in my opinion, will only leave a practice that really concerns themselves with the perfect patient experience is because they didn't deal with money thoroughly. They left an open end. And that's the biggest thing I see. Open ends, right? I mean, you don't know what that will cost. So you come back with a big number. The patient thought they were done, or there's added treatment.
Yeah.
Right.
You know, another way that I think they should be involved is when they're on the front end and they're writing the collection protocol, the dentist needs to be the one making the decision, or the owner or the leadership, of how money should flow through the office. So like, what should happen when the claim pays? How often are you sending statements? Are you sending e-statements? Do they have automatic reminders? What are you doing at the 90-day mark? Are you using collections? Because a lot of times practices, like, you know, the who not how thing, like they just say hire the who and then don't give them the how, let them figure out the how, basically. Well, I personally don't think that works with dental and with RCM. You have to have the how figured out so that your team can enforce it.
You have to be on the same page. Right. Because I always believe that in a practice, especially if we're doing a third party care credit payment or anything like that, I always believe that we should use the adage that we're trained, that the staff is trained in, that is, we don't want to present multiple bills to the patient. We want to give them one bill for the care credit month. So get paid up front. It's amazing. You walk into a practice, they have this 6-unit case, hour and a half, 2 hours of time blocked out for a big case. How much did they put down? Oh, they're going to pay on the visit they're coming in. You got to be kidding me. I mean, I tell my practices would never do that, because if we go to a plastic surgeon or we go to a big doctor, we are paid, we are done. That why are we always, it seems to be the better zip codes, no offense, have, not that I'm just saying in general, have gone to the understanding. Maybe it's because the cases are bigger, they need to get paid. But the fact is, I'm just concerned that, that is the form to me that patients take care of their co-payment and their co-insurance on these cases, those larger cases, up front. I really believe the situation, you touched on something just now, and that was just the definite, and I want to elaborate on the AR for a minute, because I'm going through a few acquisitions and transactions and just curious to know, are you involved in anything like that? A transaction where AR is being discussed, or a doctor that's looking to sell, and I'm telling advice out there, should want to be collecting 100% of their AR before they go to market, because number one, it looks like a better practice, but number two, they don't have to worry about getting 60 cents on the dollar. Have you had much experience with that?
Not in the context of a practice being sold. I really work with a lot of startups and a lot of existing practices, but I work with AR on all of them. And I've seen when you get these systems in place and get a collection protocol, like, I cannot tell you how quickly it resolves. I had one, I just trained them in November. By January, 72,000 was off their AR. I trained one in a couple months ago. In 60 days at their follow-up meeting, 110,000 was off their AR. Like, it is possible, and it definitely works. So as far as the sale of the practice, I can see 100%. Like, that makes total sense. Let's get that resolved now and make our practice more valuable.
Great. Couple of things you said. I mean, collection company, what do you think about it? Are you in favor, or knowing that it's going to scorch earth with that relationship, or how do you feel about it?
I feel that if you get your front end stuff figured out, you aren't going to rely on them. And that they are a last resort. And you're not sending your patients who are scheduled in 6 months to a collection company. You're sending the ones that you did everything in your power to collect already, and it's a balance that makes sense for you to pass it on to a collection company. And I think that some of them are more predatory than others, and I'm not a fan of the predatory ones.
Correct. I hate that. And that's something that doctors should look at after sale of a practice. Both ways. We shouldn't be predatory on our patients after a transaction. It's unfair, and you'll ruin the practice going forward, or you don't give the chance for the doctor to collect. You're just going after them. I just feel like I want to ask you a few things and hear your opinion. I had this discussion with some of the associates, and that is, they say that, I don't think Jane is very good at treatment planning or a treatment coordinator. I said, well, Jane is excellent. Maybe you should give her a chance. So they're talking money, and I do not like that. I do not like when doctors talk money. Your opinion?
I think it depends. Most of the time, I don't like it, but I can't give a blanket statement that it's always that way. Is that fair answer?
Nothing's always that way, but I understand. I always used to use the same line for every patient, and that was, that's above my pay grade. And, I felt like I said today in an interview, that, it's our job to bring the doctors so close to saying, the patients, to so close to saying yes, that the treatment coordinator is only figuring out the form of payment. If we're not answering the questions and realizing that same 4 steps that I talk about, and that is tell a patient what they need, that number 2 is the gold. And that is tell the patient what happens if it doesn't. We don't fix it. Abscess, root canals, infections, you need implants. Nobody wants that. Third is how easy it is. The filling we did last week, it's going to be the same anesthetic. And then get up and get your treatment coordinator. Because once you start giving money, you give discounts.
Yeah, that would be bad.
And that is what I found in my personal career. It's $10,000, but I do it for 80. Sure, I will do that.
Here's where I don't want to push back and disagree, but here's where I think it's okay. I think it's okay if the patient asks and that the doctor gives a ballpark if they know it. I think that's okay. I don't want them going over like the treatment plan itself. But if the patient says like, hey, I'm thinking about veneers, and they don't know if it's 500 or 5 million, I think it's okay if the doctor gives a ballpark and then passes it off.
Right. The way I look at it is this, and I love this discussion, Bri, so let's stay right here. The fact that I look at it this way, and that is that I feel the way I was trained is this phase 1, phase 2 treatment. And if somebody comes in for a big case, and I'm not talking 3 crowns, I am talking bigger cases, because that's what, we built some great offices on, but everything is important. The way I look at it, large cases, there's some extractions, there's some root canals, there's some caries control, and then there's phase 2. A skilled treatment coordinator, they're asking me to break it down. What's the total? Total around $35,000. What? Yeah. So the treatment coordinator, if we bring them to the water, explains the doctor broke down the treatment into 2 segments. The phase 1 is to clean up all the infection, get you to Dr. So-and-so to do that. Doctor's going to take care of the 3 root canals. We're going to move on. The second is to put 2 implants in, 6 units of crown and bridge, and then give you a snap-on smile to use, let's just say. And it's $35,000. The patient may say, can I do phase 1 first? Say yes, but it's all in preparation for phase 2. So the treatment coordinator can talk to them. I find that I would not go through it the way I want somebody else to go through it.
Yeah.
And it would just, you know what I mean? Like, I feel that if it's 6 crowns and I always felt like ballparking is like, give me an idea of the car. I just want somebody like you talking to me as a patient and knowing I'm in great hands, because it just has a little more breadth of affirmation, having another person talk about it. That's why I think it's another episode, but why I think hygiene is so important to helping get those cases sold. But I do want to ask you a few things. I've kept you longer because I do feel this is such a fascinating, I think it's fascinating that people like yourself, Not that I know a lot of people that have done doing what you do, but people like yourself just really going into the RCM and helping practices generate not just revenue, but generate the money that's owed to us. And without collection, as we said, I just want to ask you before I get to the three things that I want you to preface do's and don'ts before we let you go. An early sign. What are 2 or 3 early signs of a practice's collection demise? What would you think?
When there's a couple, when your collection ratio, which is collections minus adjustments, production minus adjustments is net production. Then you take your collections and divide it by the net production. So that's the number I'm talking about. Your collection ratio,
Great.
I think the very minimum should be 98%. I would love it to be more than that, but the very minimum should be 98%. However, I think that it needs to sometimes be looked at over a rolling period if you have big fluctuations in production. So I want to mention that too, because sometimes you have a really high production month, but then all the insurance, that's the next month where it pays. So, over a rolling period, if your collection ratio is under 98% absolute minimum, that's a problem. If your AR rate, like total AR and insurance AR, you want your current to be 75% of the total. So if you're a high producer, I don't care if that number is 8,000 or 800,000. 75% of the total should be less than 30 days old. And you would like the very maximum over 90 to be 7%. Now for insurance AR, if I'm honest, I do billing for a couple of offices. 7% is like the maximum for insurance AR, whereas for total AR, 5 to 7 is more reasonable. But those are the metrics that I would be looking at. Your collections ratio, your insurance AR current, and then over 90, and then same for AR current and over 90. And start to see if those start to get out of line, we need to figure out the solution.
I hope everybody out there is listening and takes notes like I've been taking notes, because I think that's some really incredibly valuable information. The collection ratio, we know it, but to be so succinct, but that 30 days, at to be 75% or less than 30 days should be 75% of collections. That's phenomenal. But I always believe that a really, as you say, rolling, but a growing, really flourishing practice should be at 102, 103%, only because of the cases that are prepaid or even more. You get 130% every month because you prepaid some large cases that are in the collection beyond the production. And now we're ahead of our associates. If it's an associate driven, you don't have to worry about that. And you've got some really good production starting the next month. There's a lot of stuff to uncover. So I really believe that. And I think that's great stuff to look for. So I want to ask you about something. 3 things to do this week. Let's give action plans. We love to do that here at Dentistry Beyond the Numbers. Please like us. And wherever you listen to us, YouTube, we're booming. I think we can use, we can always use people that are interested in growing a business. And that's what this is about. Quality and growing and getting it from the best. Give me 3 things somebody's going to leave us today and say next week, Monday, I'm going to do these 3 things.
Okay, so the first thing is run your KPIs. Start tracking them. Use an Excel sheet if you want. I think that team members that use an Excel sheet or like a tracker they are tracking versus like a dental intel type of thing. If they are tracking the numbers they are responsible for, they are more likely to take ownership of them. So start your tracker today. And then run your insurance aging report and follow up on every single claim that's over 30 days old this week or next week. By the end of next week, set a goal if it's too long to do this week. And then sit down and write a collection protocol. Tell your team exactly what you want. When are you getting the insurance breakdown? How are you estimating copays and forcing denials? What should you do when insurance pays? What should you do at the 30-day, 60-day? What technology do you have today that you can use? And by the way, I have a template. It's free, a DIY template for the collection protocol. You just answer questions. It makes it for you. Email me. I will give it to you. So those are my 3 things. KPIs, insurance, AR, and write your collection protocol.
Key practice indicators or the KPIs. Give us a couple, throw some at them. So let them feel what you're looking for.
So the KPIs that I think the most basic trackers should be are, like we were talking about before, the insurance AR total, the current, which is less than 30 days old, the over 90, same thing with the full AR, total, current, and over 90, and production, adjustments, collections, and honestly, depending on your practice and depending on the person tracking it, there's so many things that you could, but we're talking about money today. So I think those are a great place to start.
Treatment and otherwise, I know. Treatment plans unscheduled and so on and so forth. I mean, the information you just unleashed in the last 8 to 10 minutes is amazing. But give me 3 things to avoid that one can do in an action plan.
Stop under collecting in the name of compassion.
Yay!
Stop feeling guilty about asking for money. And don't wait to bring up third-party financing until the patient asks. Bring it up in the beginning. If you're presenting a $30,000 treatment and you have a financing option that's spread over 5 years, say that at the beginning. You know what? And if you know like what the estimated payment is, when you say the $30,000 and the $800 a month payment or whatever it is, that can take people think in terms of monthly payments. So that takes a lot of pressure off of them if they can't afford to pay that $30,000.
Great point. And wow, amazing. I must tell you that I'm not sure people will know the people that we hire. So the question becomes in my mind, hiring somebody like a Bri Richardson is intended to collect money, but also take away that person in a practice. Are you a staff? Are you payroll savings in the end? Is that the goal? What is the goal as far as hiring your company and you to handle our AR? Is it something that will help our payroll is what I'm asking, or do you not suggest that?
So if you were to work with Elevate My Practice, I'm actually
to Elevate My Practice, your company, Elevate Your Practice, Bri Richardson. She's going to leave her email and hopefully phone number so everyone can reach out. But yes, I'm asking is, they say AI is going to take away a receptionist at X number of dollars an hour. Is that something we could think about where we have a funnel, a machine that we give our AR and all our collections to, and they take care of it?
So I don't know if I'm answering the question properly, but I want to clarify, I am not going to do it for you. I train your team how to be armed with the skills to do it themselves.
Thanks.
So there's no replacement of anyone. Let's empower the existing people to be able to do it in a systematic way. And also it decreases so much stress. One of my doctors I just trained said it really took, doing the training took away like the emotional part of looking at this AR and feeling bad or feeling guilty or whatever it was. And it just gives a systematic approach and a process.
That's amazing. I did not, something, in all respect, I must come clean. I did not know that you were a trainer to our staff. That's wonderful. So we're not throwing it at you and relying. We're relying on the same team. We're just making sure. Do you give a time frame of how long you work with our team? Can you go into that for a brief minute on your services?
Most of my offices that I work with do a 90-day engagement where we'll do an on-site training or virtual, and then we have follow-up meetings. And the follow-up meetings are to kind of iron out the kinks in the systems that we just implemented. But honestly, what we use them for even more than that is accountability. And most of the time, by the 90-day mark, those ARs have dropped, I am not kidding you, 47% or more if they actually implement the system.
And mindset shifts, change of minds. Is there a different culture when you leave? And what do we work on? What do you think?
Well, to quote one of the ladies that I trained in January, I don't dread coming to work anymore.
So it's great.
100%. There's a mindset.
We're doing work for nothing, and we're paying for other people's work. There is nothing worse of it. Elevate my practice. Bri Richardson, you are a delight. You are such a wealth of knowledge. I really want to tell my listeners and myself, truth be told, I reached out to Bri and I'm still thinking about it and was still going to reach out to Bri. I'm really blown away by your knowledge. Where could the listeners find you? Where can we all reach out and hear your level of expertise in this field and hear some gems?
You can find me on my website and pretty much every social media. My website is elevatemypractice.com.
Great name. Beautiful. Bri, thank you. I hope this was a good discussion. All right. It was something that I know is so important for our listeners. It is part of what I am preaching to my doctors about understanding their collections and their money because they're running their own business. So I think at any level, like you alluded to, associates, owners, doctors are doctors, and collection is collection. So thank you so much. Elevate my practice. Bri Richardson, thank you. Good luck in the future. And we will see everyone soon. Thank you, Bri. Hi, everybody. Again, this is Marc Liechtung, Dr. Marc Liechtung, Dentistry Beyond the Numbers. As Bri Richardson just left, I was blown away by the knowledge base that she has, and not only insurance, but the patient's experience and how important it is for us doctors and our practices to collect money. Collecting money is what we need to sustain great materials, great staff, great teams, great locations, nice offices, technology. It's in our right and the right to care for our patients. And Bri is a young person who's been in this field and worked her way up and really understands it. To me, elevate your practice is fantastic because one of the drawbacks that I learned today was I really thought Bri was somebody that came in and worked and then implemented, we removed our materials, sent it to her, and she collected, and getting rid of a member of our staff or our team. And that would be very devastating if we like that member but she comes in and trains. So she comes in, oversees it, trains them, and we then hold people accountable to that percentage. Great stuff. I just want you to know how it turns into the Hamsa, and that is we need to be the captains of our ship. We don't need to be out in front collecting money, but we need in the back knowing that our percentage is high and we're not running at a very negative rate of collections or a low rate of collections because we're not going to have any doctors or materials to work with. This is Marc Liechtung, and good luck, and I will see you next time. But we are growing. I'm very excited about the direction of Dentistry Beyond the Numbers. Great interviews. And I hope you're picking up some really valuable tidbits. Thank you again. We'll see you on the next episode of Dentistry Beyond the Numbers. Like me, follow me. Thank you.